Welcome to Talk with Tara, the podcast where we dive into the bold, the funny, and the fascinating. I'm Tara, your host, bringing you unfiltered conversations on life, love, and everything in between. Hit that follow button so you're always in the loop. And now let's get started. I'm so excited. Today's guest is Dr. Rajaie Hazboun, a fellowship-trained plastic reconstructive and aesthetic surgeon specializing in surgery of the breast, body, and face. He's now a part of the MAAS Clinic in San Francisco in Pacific Heights. Dr. Hazboun is passionate about personalized patient care, crafting tailored treatment plans that yield natural, long-lasting results. He has a reputation for utilizing cutting-edge surgical techniques and maintaining the highest standards of safety. He's not only transforming bodies, but he's building lasting relationships with his patients all along the way. Just before we begin, I just want to make a quick disclaimer. The content shared in this episode is for informational and educational purposes only and does not constitute medical advice, diagnoses, or treatment. Always consult with a board-certified plastic surgeon for procedures. Individual results may vary and all surgical procedures carry risks. The podcast, this is for entertainment only. So with that, we can begin. My first question I want to ask you, doctor, is tell me how long you have been really focused on the breast and the body.
So I've essentially my whole training and my practice has revolved around essentially the body and the face. I graduated med school in 2011, and ever since I've done general surgery, I've done plastic surgery, and I've done aesthetic surgery. I started with general surgery, essentially treating cancers of the breast and doing mastectomies and lumpectomies and such. And then I progressed into doing more the reconstructive and eventually ended up doing the aesthetic aspects of the breast. So I'm pretty well versed in breast surgery.
Yeah, and I know your results are very beautiful, and you do a beautiful job when it comes to the breast and the body. Liposuction and mommy makeovers. And so we're going to ask you a number of questions. So I have a warm-up question for you, since you've been a plastic surgeon, when you meet people, men and women, do you size them up, or can you turn that part off of your brain and not see what's wrong with their face or their body?
It is hard to turn off. Eventually you can, but once you get to know the person like deeply, like the superficial part kind of like no longer matters, but it's hard to turn off. So it's a hazard of like the practice.
Yeah, it's like a psychic. You always wonder if they can turn off their psychic abilities. Not to compare you to a psychic, but when you do have an ability and you're able to see people with a certain perspective, it's probably really hard to switch that off. Have you always been interested in plastic surgery, and when did you find that this was kind of your niche?
I made the decision, like completely dedicated my future to plastic surgery around my third year of general surgery. But I did know, and I did have a strong idea back in med school that I wanted to do plastic surgery. I made that call during my general surgery training, but I've always been into plastic surgery from essentially they deal with everything, every part of the body, from face, body. In addition, it's kind of a progressing part of medicine. Like we haven't peaked yet. It's not a standard thing yet. There's a lot of innovation in it that you can be part of. And there's an artsy part to it. I'm into to draw and stuff back in high school and early med school. And plastic surgery has a lot to do with art and how you appreciate the form and all that stuff and beauty and so forth. So I've always wanted to be part of that.
Yeah, and plastic surgery has become so mainstream. I mean, when you're on Instagram or you're on TikTok, one of the topics that's been coming up more and more in conversations, especially with me and women that I know in my circle, is the decision to remove breast implants. And some women decide to remove the implants. Some women decide to get a lift and a new implant. There's such a growing curiosity to this and how women feel in midlife. Some women are like, got these big breasts. I went too big and now I'm married. I have kids. I just don't want them anymore. They're just saggy and I just want them out. So I was in the car in an Uber on my way to the city on Saturday night, and we had this conversation because one of my friends said that she just wants them out. She doesn't want the implants. She's been looking around. So let's talk about what explant surgery, that's what it's called, I believe, and how the demand has evolved in the past few years. And have you noticed an uptick in this?
Sure. So just to start it off, I would say implants are not inherently good or bad for you. Essentially, going for an implant is a personal choice. Some people believe that that would add to their aesthetic or believe that they need it and will make them feel better about themselves. And eventually, like you mentioned, some people either decide on like downsizing or just plain out taking them out, either just for the aesthetic again, like they're getting older, they don't want that attention, or they're just worried about like things they hear like in the media with regards to like breast implants or like on social media or otherwise, that they just want them out. And it's a very, very valid point. And again, it's a personal choice that goes back to them. And every plastic surgeon is happy to see them and kind of consult on that matter. The decision on whether to do a lift or not is a little complex. So you have those implants, if you've had them for a really long period of time, they weigh down the breasts. They can stretch the tissues. The breast that you had before placing them is not the same breast that you're going to have once the implants are out. But that doesn't necessarily mean that you're automatically going to need a lift, because again, if you had a huge implant, that's different than having a tiny implant in there and just wanting that one out. So it is kind of like a personalized approach. You can take it out and weigh it out and see how your breast will look, or you can decide on having a lift under the same setting. Because if you're having some droopiness to your breast before you even take out the implant, then most likely you're going to have some droopiness once the implant is out. Then, like once you come and see me or other plastic surgeons, if you already have that droopiness and you want the implant out, then by default, we're going to tell you, like, if you want a better aesthetic once the implant is out, then most likely you're going to need a lift. But that doesn't necessarily mean that you have to subscribe to it. This is a recommendation. And again, you can always go back on your decision if you take it out and you notice that you don't like how it looks with the implant out, to either replace the implant, to have a lift, or have a lift with a new implant that's smaller, or have other approaches. And there's a lot of tools in our repertoire now, much more than we used to have before.
Right. So what about the patient who says, I want my implant out, I want a lift because I nursed and now my breast, and I've aged, my nipple is like at the bottom of my breast. I want my nipple removed and moved up. And then they have the scar. So I personally have met many women who have done that surgery, and they never complain about the scar. They always love the result of that surgery. I mean, that's been my experience. So I just think like that scar could be unsightly, just having the anchor scar or that line down your breast or the scar around your nipple. I also hear that surgery can be complex because the bottom of the breast, the tissue is really hard to heal at the very bottom. Like the blood flow doesn't really work as well there. And so it's a real deliberate, careful healing process. Can you tell us a little bit about that and about the scar, what you think about the scar? Because you've seen many scars. You've done this surgery. And what are the results like long-term, 6 to 12 months out? And what are some laser? I think you could do laser and things like that to minimize the scar.
Yeah, so I would start off by mentioning that not everybody needs the same lift. Like the degree of droopiness that you have, the degree of excess skin, and in which kind of vector you have that excess skin. So if you have excess skin on both like the horizontal and the vertical vector, then you might need more of an anchor kind of scar lift. Or if you only have that essentially in one vector versus the other, you can either have the lollipop lift where there's only a vertical scar in one of the areola, or you can have a circumareolar lift, which just goes around the actual areola. That one has very limited uses just because it only moves your nipple around 2 centimeters. So if that's the only distance you need to move the nipple, then that might be a good option for the patient. The other thing is that when you do the circumareolar lift, it tends to flatten the breast a little bit. So you lose a little bit of the projection out of it. The vertical lift, again, it depends. If you don't have a whole lot of excess in the horizontal plane and so forth, then that might be an option. And it's a great option and it works great, but there's a lot of hand holding at the beginning. So straight out of the bed of the surgery, you're not like the breasts are not going to look great because there's a lot of settling that needs to happen. You're essentially recruiting some of the skin to become part of the chest wall skin and kind of lift up the breast. There's like a lot of nuances to it, but essentially it's going to look a little conical. It's not going to look very rounded initially. And it takes around 6 to 8 months to settle down and kind of look much better. And during those once. The patient is always like not happy with the result, very worried. So there's a lot of hand holding that goes into it. And if the patient is like willing to go through that stuff and they are a good candidate for that surgery, then by all means, that's a good surgery. Coming to the anchor type incision, that one essentially is the workhorse of breast lift. It takes the most skin out. So if you have poor quality skin, especially at the bottom of the breast, then that one kind of takes a lot of that skin out. It takes the most like stretch marks out of the breast and gives you essentially a good looking breast on the table. But it has the biggest scar burden. And the point that you mentioned at the bottom of the breast where essentially the three corners meet, it's the triple point essentially of that incision. That one has the worst blood supply to it. Doesn't necessarily that you're always going to have a breakdown of the wound or otherwise, but it has a higher likelihood of having some breakdown in that area.
What does that mean?
As in like having a small wound where the 3 points meet. So you have two triangles from the upper part and the horizontal incision from the part. Where they meet, the blood supply is on the poor side. So some of that skin in the triangles where they meet might not make it. So you might have a small wound over there. Eventually it will heal. It just takes a little time.
Takes time.
Yeah, and the scar might look a little like you might have a small triangular scar at that area.
Okay, so, but eventually it heals.
Yeah.
Okay.
Like majority, I would say, like never say never in medicine.
Right.
Not 100% in medicine, but I would say like 99.9% will heal. But
you just have to be patient.
You have to be patient, and there's some stuff that nowadays, like there's a lot of improvement in essentially the type of sutures we use, the type of adjunct stuff that we use to minimize that. For example, like there's a new device that I've been using. It's called the Bridget device. They're essentially like plastic clips that go on the outside of the skin. You still put in sutures and all, but those clips kind of offload the tension on that area. Rather than having poor blood supply and a lot of tension pulling it apart, there's less tensions. It will heal much better. And even if you have a breakdown there, it will be much smaller than it used to be.
Okay, that's good.
There are other stuff as well that we use that minimize that and reduce it. But again, there's nothing 100%. But even if you end up with some scars, there's some lasers like you mentioned. You start off with the IPL or the BBL laser. Essentially, it takes away a lot of the redness that the wound have. Eventually, most wounds kind of fade away around like they start fading away at the 6 months to 8 months mark. But this kind of speeds up the process. And then eventually, if you don't like the texture of the scar, or there are other lasers that you can use, or like dermabrasion or other devices that we can use to kind of blend it in better with the skin that will improve on the scar burden.
Okay. What about, let's move to, so that's really interesting. Are these explants, are you seeing them more than usual, or do you think it's just always been pretty much the same?
No, I think that it's actually kind of increasing for more than one reason. So I'm not sure if you've heard before, there used to be a lot of textured implants. Textured, like the outside of the implant has some roughness to it, so it would stick in place and won't move around. So a lot of the older implants used to be anatomically shaped, so they're like teardrop shaped. And they don't want them to flip, so they won't look good. In addition to, there were some studies that showed that when the surface is not smooth, there are certain cells called the myofibroblasts. They essentially kind of like a hybrid between kind of muscle forming / fiber forming cells that usually go with inflammation and healing. And those won't be able to line up perfectly to cause what we call capsular contracture, when the capsule around the implant itself starts contracting on the implant and shaping it. And that's one of the potential complications of an implant. So with the textured ones, they had less chances of that because the surface was not smooth, so the cells wouldn't line up correctly to kind of cause that compression on the implant. So they used them a lot, but then the way they used to cause that texturing on the surface, they found out that it causes this really rare kind of cancer, lymphoma. It's like breast implant associated giant cell lymphoma, large cell lymphoma. And that was very unique to those kinds of implants that they were taken off the market. But they made a big like they were big news when it happened and they were discovered, although like there weren't a lot of cases. I don't have the exact number, but at the point when they were withdrawn from the market, it was around like 80 cases or something worldwide. But still, like if you have any doubt about like the safety of a device, you kind of pull it off market. And when that happened, it kind of hit the news, and like a lot of people got worried. Do I have a textured one? Do I have a higher chance of having that kind of lymphoma? And so forth. So that was one reason. The other reason is there was a rise in people believe is breast implant associated disease, breast implant disease, essentially. But to this day, we still consider it as a diagnosis of exclusion. Like it hasn't been that there is this kind of disease, but you can't rule it out at the same time. So the way you kind of diagnose it, unless the patient straight up just wants it out, then that's their choice. You can take it out. And usually once you take it out, if it was truly breast implant associated disease, then it kind of like goes away. But the way if they want us to diagnose if there's symptoms, which are usually non-specific symptoms, like you're having some joint pain, some rash, or other kind of symptom that you're attributing to the implant, then we rule out pretty much every other possibility before we diagnose you with that diagnosis. So we can send you to a rheumatologist. They can work you up for a multitude of possible illnesses and diseases. And then if there's nothing, then we can diagnose you with that. But like there's no proven diagnosis straight out of the bat, like, oh, you have breast implant disease,
Right.
You just diagnose it as exclusion. Or if the patient wants to take it out, we take it out. But there's been a lot of conversation about those kind of diseases, whether on social media or just social circles, that people got scared and like were driven away from implants. Although, to be honest, silicone is one of the most inert kind of substances that you can have. It rarely reacts with your body, and especially like the newer implants that have more of a gummy bear consistency where even rupture, it doesn't leak that much. So, and like if you think about it, even babies, like their bottles, their accessories are all mostly like silicone, like we use it on kids. So it's pretty inert. But again, at the same time, if you cannot rule out something and the patient is having some symptoms, then you cannot just brush them off. And if we rule out everything else, then we diagnose them with breast implant associated disease. Or if you just want to go natural, there's a move also towards like smaller, better shaped breasts, but smaller breasts, like we're no longer for like the Pamela Anderson look or the Baywatch look, we're going more towards what they call whether tennis breasts or yoga breasts or, ballerina breasts. Good.
Oh, I like that. It's a trend.
Yeah, it's a trend. So they're
feminine, yeah,
athletic, like it goes with their body type, especially with individuals who are not like they're more fit and they want their breasts to reflect their fitness. So they want them to be shaped well, like rounded, perky, and all that stuff, but they don't want them to be huge.
Right.
And they move towards that. And you can achieve decent size breasts and good looking breasts without implants, but you can also kind of achieve that with smaller implants that you don't always have to go with the bigger ones.
Exactly. And the implants I'm sure today are much safe. Well, you were saying they've always been pretty safe, but I'm sure they're much safer today. They're just, everybody's watching themselves. So especially after the one about the texture. I do have a question before we move on. How long is the recovery if you get the lift and the explant? I heard the explant, just taking the explant, the suture, it's not that difficult at the recovery, but the lift can be a little bit more difficult. How long do people have to be off of work or away from exercise?
So taking out the implant, just purely taking out the implant is a very simple procedure. It takes less than an hour, unless you need to take some of the capsule out, but usually it takes less than an hour. Small incision, like usually we go either through your old incision or a small, like a different but smaller incision. Essentially, we take it out, wash out the pocket and close it, and then you're good. Usually, like, to be honest, if you work at a desk job or something to that effect, you can go back to work like within the next couple of days, like once your anesthesia wears off and you're no longer on like pain medication. It's plain and simple. I would still probably recommend not going for like the really, like you can always go for a walk. You can always kind of like go for, and even with just the explant, you can go back running pretty soon, but probably not doing a whole lot of like upper body weightlifting until like around the 6-week mark, I would say. Okay. With the lift, it's a little more complex because you have like bigger incisions. You don't want to put a lot of tension on them that they would open up. You don't want to sweat a whole lot that, like the incision would be super moist that they would get infected and so forth. And then I would say like closer to like the 6-week mark for sure for like exercises if everything is healing as planned. But you can still walk day one, to be honest. Like you can go if the weather is great and not raising your blood pressure that much, just walking plain
Right.
ground with day one. And going back to work, it would depend on your comfort. So if you're not having a whole lot of pain, you're doing a desk job, then within a week, you can probably go back to work. If you're
Okay.
lifting stuff above your head, something to that effect, then you might want to wait till 6 week mark. But you can still kind of do the lighter work earlier.
Okay. Okay. That's good. That's good to know. Let's move on to some other procedures. Now, so women in midlife tend to get a little bit of a tummy, even if they're working out a ton and they're watching their weight. It's something that's very common. I'm sure you get a lot of requests for a tummy tuck, but what if the woman is athletic? And I think with the tummy tuck, what I understand, because I've had people who've had that in a mommy makeover, the incision's pretty big at the bottom of your stomach. Is there a way to avoid that, or do you normally have to get that if you get liposuction?
So it depends on what the issue is. So there are multiple factors on deciding whether you need a tummy tuck or not. First of all, whether you have skin laxity above and below your belly button, that's one of them. Whether you have the fascia itself, essentially it's the covering of the muscles. If that one is stretched and the muscles are kind of parting more from like the midline, that happens with just having kids or like being overweight and then losing weight and stuff, similar issues, then you probably need a tummy tuck. That way we can actually lift up the skin and the fat and suturing that fascia and tightening it again.
The results, it's like a flat stomach with nice skin.
Yeah, flat stomach, and it actually brings in the waist as well. You get
Oh,
more
nice.
hourglass kind of shape. And it actually increases your core strength when the muscles
Oh,
are acting the way they need to work, like when they're oriented the right way. Because like with time, like they separate and they're no longer
right.
directly like straight up and down,
Yep.
you know. When your rectus muscles are kind of separated, they don't have as much pull. So when we bring them back together, your core is stronger. I've had patients, we can be blunt, having like incontinence before that, postmenopausal women, after having multiple kids, having some incontinence that actually went away after, like increasing their core strength. Some people that practice yoga or do other kind of activities that felt like they had more strength and they were able to either do better at their
Mm-hmm.
exercise or their yoga. It actually increases your core strength. So there's a lot to it, but the biggest factors are whether you need to remove skin from above and below your belly button, and whether you need to plicate the muscle and the fascia in order to strengthen the core and bring things together in the midline. Other factors can affect the length of the incision. Like we always try to hide it and put it as low as we can so that you can hide your bathing suit or otherwise. But in some individuals who don't have a whole lot of skin to pull it down and their belly button is pretty high, then you might end up with a small vertical scar. We pull it as much as we can, but there's a limit to how much we can pull things down.
Right.
And the other thing is like horizontally, how far we have to go will also depend on how much skin excess there is. And if we have to chase what we call dog ears, which are the when essentially your incision kind of pooches on the side and you don't want it pooching, you want it flatter, having like to extend that incision a little bit might give you a better look. But in general, there are some procedures that we can do that might bring you to a smaller incision. You have to be a good candidate for them. Like
Mm-hmm.
tuck that you can do where you're not doing anything to the muscle and you're not taking away any of the skin above the belly button, but just the skin at the bottom of the belly. And some people just have that and just want that addressed. Then your incision would be smaller than the total tummy tuck incision. And
Yeah.
then
And then when you do the liposuction, how do you make sure? I know someone who had liposuction many, many, many years ago, and their stomach ended up looking, they didn't have a big incision, but their stomach ended up being kind of lumpy looking. How do you not get the lumpy look?
yeah, so people think that liposuction is like an easy procedure because there's been a lot of non-plastic surgeons actually doing
Yes.
liposuction in other places.
Dermatologist.
Yep. And I would say it is like it might be like simple in concept, but there's a lot of technique and a lot of things that go into how to do liposuction. And even an experienced person can sometimes have issue with that. But the thing is, when you take away fat, the skin that's on top of the fat will get loosened. So unless
Mm-hmm.
you're young, and your skin has a lot of elasticity that it will bounce back, then most likely you're going to have some skin redundancy. So you might end up having to couple it with like a tummy tuck if you're doing the tummy or an arm lift or otherwise for like other parts of the body. Or it's a little looser skin, but not a whole lot of looseness. Then you can add an energy device, such as there are multiple different energy devices like BodyTite, Renuvion, and so forth. Each one has its own benefits and like caveats, but you can couple it with that. But that's not even talking about the
Wait, I
lumpiness.
don't know what's an energy device. I've never heard of that.
Right. So energy devices are devices that you can use the same incisions that you do the liposuction with. You insert them. They have like their own like cannula looking devices, and different ones work differently. For example, Renuvian uses what we call plasma energy, and it kind of shoots energy to the undersurface of the skin. Like any protein, like the proteins within the skin, kind of coagulate and contract when they're heated. Just like when you boil an egg, how it turns from like being loose into like more coagulated and so forth.
Mm-hmm.
Contracts a little bit. So the skin does that, and then it's kind of like strand wrapping like your body with the skin.
Wow.
It has limitations, so you
Uh-huh.
can't do it on someone who's got a lot of loose skin. Like it won't work. It would be just for nothing. But
Right.
if it's a small amount of skin looseness, then that can account for it. Or there are other devices that work on more of like bulk heating, such as body tight, and they're a different way of working, but essentially the whole concept is you're heating the skin from the inside and causing it to coagulate.
Okay. Never heard of that. That's so
And that's not even
interesting.
talking about the lumpiness. There's a lot to go into, like how we try to avoid lumpiness. Because
Yeah.
lumpiness happens from fibrosis, and
Uh-huh.
where you're doing essentially liposuction, you're causing trauma. And the body reacts by that by kind of forming scar tissue. And that scar tissue forms on the inside and can tug on the skin in weird directions. In addition, if you take the fat superficially, the skin has multiple levels of fat. You have superficial fat, and then you have the deep fat. So if you take a lot of the superficial fat, then the skin will kind of collapse on top of it. You'll get some
Mm.
lumpiness. In addition to other factors. So there are some ways to avoid that. There's a lot of papers that talk about it. There's the safe methods. Essentially, it's the same devices, but the way you do the liposuction. So you essentially start by separating the fat using the cannulas without suction, essentially,
Mm.
just to separate the fat and have it loose. And then you go back in there and do the aspiration where you take away the fat. And then you go back again without the suction and you redistribute the fat. And that's one way
Mm.
to avoid that lumpiness because you're redistributing the fat and you're doing it in a way that things are kind of even. In addition to other factors, like after surgery, we really ask the patient, it's very uncomfortable to wear the compression garment and the foam and all that stuff, but it's very important. I would say like the aftercare is almost as important as the surgery itself. Yeah, because if you don't wear your foam underneath your compression garment, every crease in the compression garment will fold and will push on your skin. It causes a dent. And that,
Oh. So you wear a foam, and then on top of the foam, everything's smooth. Then you compress.
yeah,
Okay.
foam distributes the pressure on the skin so that it's not in just one area where the garment kind of folds. It
Got it.
around. In addition to like, there's a lot of move towards like lymphatic massages after surgery that helps break down those kind of fibrosis and it helps kind of the blood supply for the skin. So I usually recommend for my patients that come in for liposuction really wearing their garments like we recommend them to, wearing their foam as recommended, and doing their lymphatic massages, which is very important as well.
Oh, interesting. Okay. Wow. So the aftercare, ladies, is you have to do your homework.
Yeah.
Okay. What's the most popular surgery that you perform?
I would say liposuction is very popular.
Yeah.
And it's been for many years, and it still is. I'm getting a lot of breast lifts, to be honest.
Uh-huh.
Recently, like in the last few months, I've been doing a lot of breast lifts. The majority, to be honest, are coupled with an implant, so it's like a breast implant with a lift, and I think you get a beautiful result with that. There are some ways to kind of get similar results, not necessarily the exact same. I would say it's hard to recreate what an implant would do to the breast because an implant is very structural. It has a shape to it, and it pulls.
Mm-hmm.
Once you put it in there, it shapes the breasts the way it looks. But I've been very successful at doing some other kind of coupling other techniques to get a very well-rounded full breast, especially at the top, what we call the
Yes.
upper wall. So if the person has enough fat, we do a lot of fat grafting.
I was just going to ask you about that. Fat grafting. Yeah.
Fat grafting is an amazing thing and it works great, but if you want it for volume, might not be like the best bet for you.
Doesn't the fat go away if you exercise?
Yeah, if you lose fat, it acts like the fat in the rest of your body. So
Right.
if you lose weight, you will lose some volume. In addition to like not all the fat that you place in there is going to survive.
Right.
Fat you bring taking away from an area where it had blood supply to an area where it doesn't have blood supply and has to form new blood supply. So all the droplets that you put in, if you want them to survive, they have to be in communication with tissue that has blood supply in it. So there's a limit to how much you can inject in each session. If you inject the part, it forms like lumps essentially, and the middle part of the lump will essentially die off because it's not in communication with any blood supply. So you're not going to get the same result. So like in general, if you're doing fat grafting for volume, it would barely get you like half a cup size to a cup size at the most. That would be like,
Oh, wow.
So if you're looking for volume, fat grafting probably is not the answer. Unless you're doing multiple sessions and all of that stuff, then maybe you'll get to a volume that you like. But it's good for shaping. So you can put it like in certain areas that you want it to be bigger, and that will do a good job. When we were talking about explants too, so like I've had great success with doing like explanting, fat grafting, and a lift together. And I've been using also like this new technique. We call it the internal bra. Essentially, we use a certain kind of mesh. It's an absorbable mesh, so it's not permanent there, but it holds everything together. It holds everything high for around 6 to 8 months while the body grows into that mesh. It fades away, the mesh, but the body already formed tough tissue where the mesh used to be, that it will give you a longer lasting result. So
where does the mesh go?
The body eats it essentially.
Oh, it does?
Yeah.
It just kind of disappears into your body. Are there any negative effects with the mesh just kind of disappearing into the body?
Not necessarily, because they're usually made of material that is either like sugar based or something that the body just absorbs.
Got it. Okay. Got it. Okay.
Similar to the materials they used to make sutures, essentially.
Oh, okay. Like the ones that disappear into your body. Okay. Oh, that's interesting. So it's like a mesh bra.
Yeah, essentially.
Keeps everything in place. Yeah, I've heard of that as well, that works really well. What about Ozempic body? I was on a call the other day, a webinar with women on hormone replacement. They were talking about that, and they were talking about Ozempic and how people are losing a lot of weight, and then they have like all this hanging skin. Have you run into that?
Yeah. So there's a big rise in like essentially body contouring in general.
Yeah.
It used to be like there was a revolution in essentially bariatric surgery around early 2000s to like the mid teens, essentially, where we got really good at doing bariatric surgery. I mean, like the laparoscopic surgeons and like turned robotic eventually, but they were great at doing that, and people were losing a whole lot of weight and eventually coming to us to do their body contouring. But now there's a big uptake with people using GLP-1s, essentially, whether it's Ozempic, drizepatide, or other medications, and they're losing almost like they're having almost comparable results to bariatric surgery.
Yeah.
They're losing a lot of weight, and that's a great thing. First of all, like you're not being exposed to like the surgery and the risks of surgery, and in addition to that, like it improves pretty much your overall health, like better kidney function, less diabetes, less and so forth, like better heart and so forth. But like this is a new indication for the reuse, so we'll have to kind of see if there's something that might come up in the future that might lead you to think that it might not be the magical drug it is right now. But now it has tons of benefits for people that it's indicated for. Usually there are certain kind of recommendations for BMI and so forth. But yes, you lose a lot of weight and you lose it everywhere. So if you're a woman, you're going to lose it in your breasts. You're going to lose it in your buttock area. You're going to lose it everywhere. So you're going to have a lot of
arms, like the skin, yeah.
And then you'll have to kind of think, like once you visit your plastic surgeon, you kind of want those issues addressed. You kind of have to discuss it with your plastic surgeon and kind of figure out what your priorities are, because it's a lot of surgery. Like the arms, we have a solution for it. It's called brachioplasty. But that's like one surgery. And then your legs, you have a thigh lift. And we can go down that rabbit hole where there's different kinds of thigh lifts. But whichever kind it is, it's still like a big surgery. And then you're talking tummy tuck. And then if they need an extended tummy tuck, if they need a lower back lift, if they need a back lift, breast lift and so forth. So there's a lot that goes into it to end up with a great end result. So you have to kind of figure out what your priorities are. You can couple a few surgeries together, but you probably can't do everything together.
Right, it would take hours. You'd be under anesthesia forever. Do you like to use, do you ever use local anesthesia for any of your procedures, or are they all general?
I would say it depends on the extent of the procedure and what needs to be done and the patient preference. patient preferences. Like that's a big
Yeah.
factor because if the person is screamers, they don't think they can tolerate it, then probably local is not the good option for them. And then there's a limitation to how much local anesthetic you can use. So if it's a
Mm,
surgery in multiple areas, then we start kind of talking about like I don't want to exceed the recommended dosing because that has its own side effects that are major. So we have to kind of remain within a certain number. So that's dependent on their weight, the length of the procedure, and so forth. So if it's a limited area, like let's say liposuction for a small area, you can do it under local. I've done even like breast augmentations under, not necessarily just local, like local with some IV sedation, but
mm-hmm.
not general anesthesia. But to be honest, if the person does not have a strong preference to that, then I would always kind of try to veer them if it's a major surgery towards the general. That way they don't feel it. I get like a calm patient that I can do the best job on. The
Yeah.
same. So like a lot of factors work into it, but we do use local for a lot of the procedures, especially if it's not like a big procedure, small area. Yeah, you can do that.
And another thing that I wanted to ask you, so at the MAAS Clinic, people can actually stay the night because a lot of times women who are doing mommy makeovers or getting their breasts done, they don't want their kids, teenage kids or young kids seeing them. I had a friend who came to San Francisco and she had some work done and she stayed here purposely. She wasn't from this area because she didn't want her little kid to see her mom having plastic surgery. So you do offer like an overnight
Yeah, so we do have like,
care.
yeah, we do have a room in the center essentially that if the patient wants it, they can stay the night. But I do understand where you're coming from. Yeah, that's kind of why it was planned that way. Because again, even if it wasn't like a surgery that shows on the outside, like you're going to be coming out of anesthesia, you're not going to be yourself, you're going to be sleepy, groggy. You probably don't want to have your kids see you that way and so forth. So yeah, like we do have a room. And again, like it depends on like the extent of the surgery and all that stuff and how you feel and what you want to deal with.
So are there this has been so insightful. I really appreciate this. I know my listeners are going to love this because you're answering all the questions that everyone wants to know. When you're choosing a doctor, what are your recommendations finding the right doctor? Like, what would you tell your loved one?
Finding a surgeon is essentially a trust relationship. Like there's a lot that goes into it. You have to trust your surgeon. You have to like your surgeon. You're going to have like a working relationship with your surgeon, and your surgeon should have like a mutual kind of feeling about it too. But I would tell my loved one or otherwise, or my friends or the listeners, look around, shop around, see your surgeons, see how you feel about them after the back and forth, ask your questions, see how they respond. If you have a bad feeling, yeah, move on. Always trust your gut feeling. At the same, yeah, and kind of measure the clinic as a whole too. Like, are you liking the environment? Because you're not going to only be dealing with the surgeon, you're going to be dealing with the whole practice, from the person that answers your phone calls to the person that sees you at the door. It's a full package, And plus, always kind of look for your surgeon's aesthetic. So there's a lot of art that goes into plastic surgery. Like what your plastic surgeon sees as beautiful might not be the same thing that you see as beautiful. Communicate what you like and kind of like see their responses. If they offer to show you before and after pictures, see those and kind of see if that works with your aesthetic. Because again, you both have to be on the same page when it comes to aesthetic, and you both have to be kind of trusting each other, kind of you're liking the environment you're at, they're making you feel at ease. There's a lot.
Yeah, I think it's good to bring pictures in. If you have a breast that a certain kind of look, to bring pictures in to say, this is kind of my dream look, whether the surgeon can achieve that or not, they can say what they can achieve and they can see what your aesthetic is, what you're looking for,
Yeah, so I always recommend bringing in like what we call like inspiration pictures or goal
Mm-hmm.
pictures. Some people kind of come in with a little unrealistic expectations, but that's a good thing because like you bring in your expectations and then you get to know what can and cannot be done. And if I cannot achieve that result for you, I would let you know. That way you're aware of that. And then and I can tell you what I can achieve. And if that's good enough for you, then we kind of proceed with it. If not, then you have the option of not proceeding with it. Again, so when it comes to aesthetic surgery, it's an elective procedure for the most time. Yeah, it does have a lot of ramifications and it improves your psyche, it improves your lifestyle, it improves a lot of things. So if we can call it elective, we can call it elective, but still, like, eventually you're doing it for yourself, and then you kind of want to show what you want and see if that's achievable or not.
Yeah. That's
And
good.
always,
Thank you.
I would say, like, if someone over promises, you'll know they're over promising.
Right.
Get that sense.
Yeah. You get the sense when somebody over promises. That's true.
Like, I'm going to make them better than the pictures you brought.
Like there's people who go to Mexico and like find some surgeon and then they come up botched, like be careful this is your body. Try to pick somebody and also it's really nice to get referrals. Unfortunately, a lot of people are very shy about talking about their surgery, or they don't want to admit they get surgery. So it's hard for plastic surgeons, like we're all wanting to know who Demi Moore's plastic surgeon is, and we'll never find out.
That's true.
She looks amazing.
Unless she wants to disclose it, like not even her can tell you that I did her.
Yeah, I mean, she looks amazing. Or Kris Jenner, the new pictures of her, people are like, what? She's 69? She looks like she's 50. So anyway, thank you so much. How do people get a hold of you if they would like a consultation?
So they can call our clinic or reach out through our website. And maybe website is probably the easiest way. That way you can kind of fill out the form with everything you kind of have in mind, and our patient coordinator will reach out and arrange for a consultation.
And I will put everything in the show notes so you can reach out to Dr. Hazboun's office and get a consultation. And thank you so much. This has been such a pleasure.
Thank you. The pleasure was all mine.
Thanks for listening to Talk with Tara. If you loved today's episode, please follow the show and share it with a friend. Stay tuned. There's so much more to talk about. See you next time.